I'm an obstetrician, and I've developed an interest in problem pregnancies. And I think the thing that I get really excited about is if we are able to take a problem that a baby has in utero and fix that. And if we didn't fix it, then that kiddie would either not survive or would survive with a major problem. We can change that course of events for that particular fetus and the effect for the whole family. To me, that's what keeps us going. We started out by seeing women who had problems in pregnancy, so mums who themselves had things like high blood pressure or diabetes or whatever. And we very quickly realized that, in fact, there were a whole host of mums out there where the problems were not in the mums, but were in the babies. I think you have to weigh the risks. I mean, there's a couple of issues that might have any impact on the baby. That might cause the placenta to separate, that might cause the baby's heart rate to drop. 22 gauge. There's no manual because it's a relatively recent specialty. And I think, for me, that's one of the most exciting things about it, because you're constantly trying to develop new techniques, you're trying to look at problems and see, can you possibly try something different?
Dr. Ryan is one of a few surgeons worldwide who treat babies in utero. He is renowned for reversing a deadly syndrome that affects identical twins.
10 days, that's right, that's what we said, yeah. The big one's got tons of fluid, but the little one, the membrane is so hard to see.
Jennifer Ferguson's twins are identical and consequently share the same placenta. Dr. Ryan checks to ensure the placenta is strong enough to last all the way to term.
Not bad, 440, buy that.
Yeah,
I mean, that's actually not too bad at all.
Okay, great.
So these guys are fine. I mean, that's exactly what it was last week. His baby's behaving well, is growing nicely. I mean, pregnancy is meant to be a happy event, and if you're told that your unborn baby has some potentially very serious problem, something that may or may not be life-threatening, something that may be associated with long-term handicap, it's enormously upsetting from a couple's point of view. Okay. So let's see.
Joanne Pantelachuk and her husband Craig have flown from Calgary to Toronto to see Dr. Ryan.
Most muscular dystrophy is diagnosed by DNA now, but there are a small number of cases where you cannot identify whether or not a baby is affected. So in your case, the only way to make the diagnosis for sure is to take some of the muscle tissue and then to analyze that for the muscular dystrophy. In terms of your placenta, I mean, if you look...
Dr. Ryan will perform a fetal muscle biopsy. This means using a needle to take a tissue sample directly from the baby's buttock.
What we're going to do today is diagnosis of muscular dystrophy, which has fairly major implications for the baby after birth. Howdy, how are you?
My brother had muscular dystrophy, and I was tested for what they could test back 20 years ago, which was rather limited. So they told me that there was a very good possibility that my children would have muscular dystrophy. I guess in a couple of days we're going to know for sure whether or not the baby has it and whether or not I'm a carrier.
So what we're going to do is to pass a needle in and then take a biopsy of the baby's buttock. Pretend this is inside. When you fire it, this fella here shoots down and the biopsy is sitting, the core is in here. It automatically advances the distance you've preset it here, which is 15.
So it's going to be 15 millimeters.
So it's 15 millimeters. The medication, and through that also...
This will be only the 4th fetal muscle biopsy Dr. Ryan has performed. Just 20 of these procedures have been done worldwide.
We might need to give the baby something. I'm going to give you something intravenously, some of which crosses the placenta, so it settles the baby a tiny bit, like you'd have for...
Early medication?
No, we give it to the baby, actually. We have to give it to the baby.
Even though this in utero procedure isn't performed in a traditional operating room, it is still considered a sterile surgery.
See, what we do sometimes, we often move the baby around. Babies often aren't in the ideal position, so we'd often sort of nudge them around one way or the other to get them in a better position for us to do the sample that we need to do.
Once Dr. Ryan has prepared the needle and identified the baby's buttock on the ultrasound, he gets ready to take the tissue sample.
Hank into the buttock here. Just measure the distance, like from the skin edge in, just from the thigh, just from the edge of the thigh. But that's okay, because we can push the other one further down. Like I've got that extra length. Isn't that right? Yeah.
To obtain the tissue sample, the biopsy needle is inserted through Joanne's abdomen.
You are there, perfect. Okay, you're there, right? Okay, so I'm just going to go straight up against this, and when I say fire, it's all ready to go?
Okay, yes. Okay, you can hear the noise in just one moment, all right?
Dr. Ryan inserts the needle from the side. careful to avoid nerves, bones, and blood vessels.
I think we actually glanced off the edge there. It's going to skin it.
Originally in utero, surgery started out as opening a mum's tummy and taking the baby out and fixing something and putting the baby back in again. I think we've learned over the last 10 years that that probably is not the way that things are going to evolve, that we're moving more towards what they call keyhole surgery, using very fine instruments, leaving the baby in utero and doing whatever you need to do while the baby is still there.
Yeah, I think because it didn't look like we had good contact there, Murray, so...
Dr. Ryan suspects he didn't get enough tissue and decides to take another sample.
Whenever you're ready, can I get the lights off here too, please? Do you have something there you can... Okay.
What I want to avoid is the sciatic nerve. If we were to hit the sciatic nerve, then that could be potentially serious if that would not be something we want to do.
Now, turn the lights on and then...
The samples are so small, Dr. Ryan needs the pathologist nearby to tell him when he has an ideal biopsy.
How does that look? Something there?
Dr. Monty Bowden checks the specimen to make sure he has enough tissue for testing.
It still feels a bit firm, yeah. More firm than muscle.
Once again, the sample is insufficient. Dr. Ryan will need to take one more.
Can I get the lights off, please? I'm going to line this up again. I'm going to angle it very... Let me just... Okay, let's go.
There's a beautiful piece.
That's more like that.
With the third specimen, the pathologists are satisfied they have enough tissue to make a diagnosis.
Good. Okay. Well done. All finished.
Thanks, Dr. Ryan.
Take it easy in the hotel this afternoon, and you can go about your business tomorrow, maybe. I think one of the things for me is for parents to be aware that even if they have something that's rare, that there is something that can be done in those situations.
2 days later, Joanne's results have come back from the lab. Dr. Ryan phones her at her home in Calgary.
Hi, it's Dr. Ryan here from Ensign in Toronto. How are you? Not too bad. Everything okay after the procedure the other day? Okie doke. Well, I've got some good news for you. We got the results back, and I just got a call from the pathologist to tell me that she's quite happy. From this kiddie's point of view, everything is fine. No, not really. Nothing related to this. I mean, you're in the clear from that point of view. Thank you. Bye-bye. Faster, do it faster.
Dr. Ryan and his wife Jane have 3 children between the ages of 5 and 11. When they decided to start a family, he found that his knowledge of problem pregnancies weighed heavily on his mind.
We were absolutely paranoid. I was absolutely convinced that each of our kids had Down syndrome until they were born, until I saw them. And it was, you knew that you were being silly because it was just the background you were working.
One for Dad.
And it gave me an extra insight into what, you know, a couple is going through when their child has been born. Gareth, no, really.
It was good.
No, it wasn't. Come on, that's not fair. You're too close for that hard. Again.
Because Jane is also a surgeon, they both fully appreciate the professional and personal demands on each other's lives.
I think one of Greg's best assets is that he's very childlike in his way of seeing the world. There are no airs or graces about him. He does what he loves doing, and it's all built on very sound base in that way.
Daddy, can I go on the bike with you?
No, I've got to go the other way, Heathcliff.
Dr. Ryan keeps in shape by cycling the 5 kilometers each day from his home to the hospital in downtown Toronto.
The timing for me has been very lucky in that when I was training, this really wasn't a specialty, it was a specialty in evolution. It just happened that when I qualified as an obstetrician, that this was something that was opening up. Originally, I was a family doc working in the Northwest Surgeries. And on the day that I was leaving, one of the other docs arrived with a patient and said, look, I'd like you to examine her because I think there's a problem. And indeed, there was a problem in that the baby was coming down sideways and the cervix had fully opened. And that's a pretty tricky situation because you can lose the baby, and in some situations you can even lose the mum. And this was in a setting where this was a group of family doctors who didn't do operative obstetrics. And so we ended up doing, which was my first cesarean section ever, with literally the book open beside us and one of the docs giving the anesthetic, and we did fine. We had the mum survived, the baby survived, and she's gone on to have 2 or 3 other kids. At the end of the day, I'm an obstetrician, I deliver babies. Childbirth still holds a fascination for me. I just think it's a phenomenal event. It's an unbelievable event. Maybe it's because we're dealing with abnormal pregnancies the whole time. That has never paled for me. So I think that's what keeps us going.
Just need to discuss a patient we saw last week. I just wanted to know when you thought we should bring her back again.
Why don't we wait and bring her back? We need to book her back for the week after next.
Okay.
When I was growing up as a kid, I had absolutely no interest in going into medicine because the sight of blood just put me off. And it was only when I would have been about 16, and I broke my nose playing football, and I went in to have it fixed. And I remember that was the first time that ever struck me, watching the guys wandering around thinking that this might actually be something that would appeal to me. I said I'd give medicine a whirl for 1 year and see what happened, and if I failed, I would do architecture, and I passed and sort of went from there. She said there was a little bit of thickening.
Dion and Scott McPhee have come from Vancouver to see Dr. Ryan. Dion has been diagnosed with twin-to-twin transfusion syndrome, an extremely serious condition that affects only identical twins.
Well, basically because they share the one placenta. There's a crossover of the vessels, and one baby's getting too much of the blood flow and one's not getting enough. So he's struggling along, so they're hoping to sort of disconnect those connections and be able to function on their own.
We're saddled with probably a 30% loss rate, no matter what way we go, as long as you guys know that.
Right. Okay.
I mean, that's something you're comfortable with.
Yeah. Well, we're not okay with it, but that's just a fact of life. Yeah.
Overall, if we look at the chances of both babies surviving, it's in the region of 50%, which don't sound great figures. However, when you compare those to the odds of survival in the absence of treatment, we're talking about 90% of these babies dying. Let's go. Dion is about 21 weeks pregnant, and she has a set of twins which are identical, and so she has one placenta and has a problem with twins where one twin preferentially sends blood over to the other twin. And what it says is it can no longer send blood around its own body, so that baby sometimes doesn't grow as well as it should. Then what we're essentially doing is dividing the placenta in two. So each baby is on its own. The baby who's going to do well is going to do well. The baby, if it's not going to do well, is not going to do well, but it's not going to affect its brother or sister. We'll get you nice and comfy before we get going.
Dr. Ryan and his team have perfected this surgical treatment for twin-to-twin transfusion syndrome. He is the only surgeon doing this in Canada.
Are you better on your side or what?
Yeah.
You are? The way she noticed there was a problem was that all of a sudden her tummy began to enlarge quite dramatically and she had abdominal pain.
Before the procedure begins, Dr. Ryan uses the ultrasound to check the position of the babies and locate the placenta.
When we look at the babies who we've lost either related to the procedure or soon after the procedure, it's generally the smaller baby that has the problem. So let's just hook
Dr. Ryan and his team must wear safety glasses because they're working with a laser beam. A malfunction could cause serious damage to anyone whose eyes are not protected.
Okay, Dion, you're going to feel a little jab in your tummy in a second, okay? We're giving a little bit of freezing initially just to anesthetize the skin. So Mum is receiving some anesthetic intravenously to help her relax. She is awake, so she can see the whole procedure and talk to us throughout. We used to put mums asleep for this, and we found this actually works much better. And Dad's here as well. I think the dad being here is a huge plus. So this is the scope that we use. We put a little telescope into her womb. We can see the placenta. We can look for the blood vessels. And then we use a high-energy laser beam to systematically block off the blood vessels one by one that are causing the problem. For me, the most difficult parts of this whole procedure is putting the scope in at the beginning. And we've had one case in particular where we had profuse bleeding as soon as that happened, and we could not control it, and we had to back off and stop the procedure. Right. Okay, folks, scope, please. So you put the scope down. There's baby. Okay. Bingo.
There's the nose, there's the lips, there's the mouth, there's the, you see, baby asleep there. That's the eye we're looking at. So that's the recipient baby that's lying on the placenta. Now, each of these blood vessels are the fellows we have to follow, because these are the ones that may pose the problem, okay? There's quite a few of them, so we're just going to take our time one by one. Right here, there's his hand, you can see that?
Yeah.
See the hand and the elbow right there. So he's actually lying on top of the placenta where we want to have a look at it.
Dr. Ryan needs to see the full extent of the placenta so he can identify all of the blood vessels running between the babies.
With twins, if the babies are connected and one baby does die in the womb, then there's a very high chance that the sibling, the other baby, will also die or will in fact sustain a stroke because its brother or sister has passed away.
Dr. Ryan begins to laser the connecting blood vessels as soon as each one is identified.
Okay, ready? That's good. Babies are mobile, they're moving all the time. Indeed, that has a couple of problems in that the baby can bump you as you're using the scope. And the one thing we don't want to do is to fire the laser when the baby's in the way. Sometimes you're firing the laser right beside the baby's face or the eye, and you can just imagine the problems if we were to fire at an appropriate time. Are you okay there? Yeah? Yeah, you ready? Just gentle breaths for a sec. No, you're doing great, actually. Don't, you're doing just fine. Baby keeps hitting me here, that's the problem. And then baby kind of sticks its nose in every so often here, so. It goes way over there. Okay. So let's keep on coming across then. Next one down. And then we're home. I think the least of these blood vessels we've ever had to do is about 4, and the most I think we had to do was 18. 16 actually. The average is about somewhere between about 6 and 10. Okay, hold your breath now, Dion. Don't try not to take a big breath like that for me without warning me, okay?
She's gonna have to breathe, right?
Okay, breathe. That's good. Okay, take a big breath, but just tell me before you have more work to do here.
Dr. Ryan has now reached the final stage of the procedure. He's about to seal off the 12th and last remaining blood vessel connecting the babies.
Okay, folks, we're finished. All over. Okay, you did really well. Really well, okay? Just going to wash some of this stuff off your tummy for a second, okay? Get this stuff off while you're...
This has been the hardest part.
Huh?
It's the hardest part.
This is the one you've been waiting for.
That went pretty well.
It was, the procedure was fine. The larger baby was stable all the way through. At the very end of the procedure, the smaller baby has a very slow heart rate. So I would be a bit concerned that that kitty may not come through this. From the outside, but very smooth.
Shortly after the procedure, Dr. Ryan joins Dion's husband, Scott, to tell him of his concerns.
I was happy with the way the procedure went. There was no bleeding. I mean, when we put the scope in and taking the scope out, it went fine. As you could probably see at the end, there was a really slow heartbeat on the smaller baby, and that's concerning. I think we're going to lose a little baby. I hope I'm wrong, but I think that's likely to be the outcome here.
Okay. What happens with the baby that's
we'll just stop
passed?
growing.
Just stop growing, just stay there,
and it will probably even shrink a tiny bit, and will be born at the time of the birth, normally.
So the next 24 hours is critical as far as...
The next 24 hours is really, I think things will be very clear by tomorrow morning how things are happening, how things are going. Yeah,
Thank you.
Not at all.
Yeah.
Okay? All right.
Thank you.
Okay, I'll see you upstairs. When we finished the procedure, there was concern that there was quite a slow heartbeat on one of the babies. And indeed, when we had a look later on, that baby's heartbeat had stopped. So the little baby passed away soon after the procedure. And that was something we had half expected. Okay, folks, so how are things?
Surviving. Yeah, finding out that the one's doing okay is giving me the strength, so.
Right.
Yeah.
Well, I think I'm pretty encouraged by the way things are looking for the healthy baby. I mean, the baby is behaving very well, so that baby is showing signs to us that it's recovering.
Yeah. If we would have kept going the way we did without the surgery, then I know I probably would have lost both, so.
Well, I think the way the cards were dealt, I know I can tell you that I think that's what was going to happen anyway.
The one gave the biggest gift of all, the life to her sister, hopefully.
Well, I think that's the way to look at it. Yeah.
Without it.
Yeah, we've gone from 2 unhealthy babies to at least 1 healthy baby, so.
Well, we can't thank you enough for your...
Yeah, it's pretty amazing.
It's created a miracle. You and your entire team were incredible.
Well,
thank you for your kind words. And
first-rate team here. Thank you so much. You guys are fantastic. You're welcome. You've made things so much easier for us. You take care.
In my own mind, I'm quite clear that this is the best outcome in this, given the particular set of circumstances. I mean, nobody wants a baby to die, but sometimes if it's destined to die anyway, then you don't want it to have an impact on the other kitty.
There are days when you know that you'll be able to do something that will turn things around for a particular fetus and for a couple, and that's enormously rewarding.
Many of the problems we encounter, many of the situations that arise, be they a medical problem or a clinical problem or a problem with a baby, they're very close to where you've been yourself, or they're very close to, I mean, it's really there, but for the grace of God go I. I think for me, if anything, it's always humbling. It always sort of keeps you awake, because you're not going to be here for a long time. You don't know what's going to happen tomorrow. So you make the most of today, really.